Good afternoon. I'd like to thank the Department of Medicine for having invited me to speak on the topic peroral endoscopic myotomy. There are two reasons why this topic was chosen. Firstly, this is considered as a recent advance in the management of achalasia cardia. And secondly, this is a procedure that we ourselves have been doing in CMC for the past 5 years. This shall be the outline of my talk, where we'll be looking at achalasia, especially in terms of the various treatment modalities. And the topic for today, poem, especially in achalasia, we'll be looking at pre-procedure considerations, the procedure, post-procedure care, outcomes, its role in different population, other indications, and the management algorithm in achalasia cardia. Achalasia cardia is a result of the progressive degeneration of ganglion cells in the myotic plexus in the distal esophageal wall. As the name suggests, there is a failure of relaxation of the lower esophageal sphincter. Later on, there would be a loss of peristalsis in the esophageal body. In the Western population, the incidence and prevalence of achalasia cardia are 1.6 and 10 per lakh population respectively. The male-female ratio is 1:1. The usual age of onset is between 25 and 60 years. The symptoms are predominantly those of motor dysphagia, where there is a difficulty to swallow early for liquids. There can be regurgitation, weight loss, and chest pain. The endoscopy would show a dilated esophagus with the pooling of salivary secretions, the presence of food residues at times, and a lower esophageal sphincter that appears tightly shut. Chest X-ray can show a widened mediastinum with sometimes an air fluid level and the absence of the fundic air bubble. Barium swallow can show a dilated esophagus resembling a sigmoid esophagus, and the lower end of the esophagus has been described as characteristically having the bird beak appearance. High-resolution manometry is used to diagnose and characterize achalasia cardia. The top panel shows how a normal esophageal peristaltic wave would appear on manometry, while the panes below show how achalasia cardia would appear where there is a loss of peristalsis. Type 2 achalasia is the one that is most responsive to treatment. And here we can see what is shown as a pan-esophageal pressurization. In type 1 achalasia, which is a later form of the disease, we see that pressurization disappears. That is because the esophageal body starts dilating and the pressure decreases. Type 3 achalasia, there is a spasm in the lower esophagus. This variant is sometimes called, or used to be traditionally called, as vigorous achalasia or spastic achalasia. The endoflip is a new modality that is used to diagnose achalasia when the other modalities are equivocal in their findings. So in achalasia cardia, we're looking for a narrowed OG junction segment and a low distensibility index. The various treatment modalities for achalasia cardia include pharmacotherapy, endoscopic therapy, and surgery. Pharmacotherapy comprises of calcium channel blockers, nitrates, phosphodiesterase inhibitors, and these have in general found to be least effective in the management of achalasia. They're reserved for those who are unfit for invasive therapy. The effects are not durable and they are associated with considerable side effects. Endoscopy therapy traditionally had been those of either pneumatic dilatation or botulinum toxin injection. In pneumatic dilatation, a balloon is taken across the lower esophageal sphincter. It is inflated with the intention of rupturing the inner circular muscle fibers. In botulinum toxin injection, the toxin is injected over 4 quadrants, and that is a form of considered to be a non-invasive form of therapy, again reserved for those who are surgically unfit. The laparoscopic Heller's myotomy with dot fundoplication has been the mainstay for Heller's myotomy for a long period of time. Here, what would happen is that the circular fibers would be approached externally where an incision is made, and thereafter we see a fundoplication. Here, the door fundoplication is being performed. In the late stages, an esophagectomy is the only option that is left, and that is because all other methods would not have done their job. And esophagectomy is also useful, especially when you're considering a risk for malignancy, which is sometimes seen in achalasia cardia. Peroral endoscopic myotomy is the new kid on the block. It is an endoscopic equivalent of surgical myotomy. It's a form of third space endoscopy. First space endoscopy referring to that being done intraluminally. Second space endoscopy is one wherein the peritoneal cavity is approached. Third space endoscopy refers to something that is done intramurally, specifically in the submucosal space. A tunnel is created in this region through which a myotomy is carried out. The concept of endoscopic myotomy came about in 1980 by Ortega and colleagues. Over the years, it was found to have been associated with severe complications and was abandoned. In 2007, POEM was first described by Pasricha and others in a porcine model. In 2010, Inoue in Japan performed the first ever POEM in humans. They showed 100% technical success in 17 patients. In India, this procedure was done for the first time in 2012 by Dr. Amit Medeo in Mumbai. In September 2016, we did the first POEM in our center. The indications in achalasia cardia are as follows. In type 1 and type 2 achalasia as an alternative to pneumatic dilatation and lap-Heller's myotomy. In type 3 achalasia, where it is the preferred treatment of choice, and also when a situation of post-prior treatment for achalasia. This includes even POEM, a previous POEM. The contraindications would include severe erosive esophagitis, significant coagulopathy, cirrhosis, severe lung disease, any prior therapy that may compromise the integrity of the esophageal mucosa or lead to significant submucosal fibrosis such as radiation, endoscopic mucosal resection, or radiofrequency ablation. The pre-procedure evaluation would include history and examination, the calculation of the Eckhart score, an upper GI endoscopy, high-resolution manometry, and a barium swallow. Eckhart score is a sum total of symptom scores for dysphagia, regurgitation, chest pain, and weight loss. A total score of more than 3 is considered significant. Preoperative preparation would include admitting the patient a day prior, administering liquid diet for 1 to 2 days, cessation of anticoagulants and antiplatelets as per the current guidelines. Broad spectrum IV antibiotics is given before the procedure. We use a high definition therapeutic gastroscope onto which a transparent cap is fitted at the tip. Instead of air, we use carbon dioxide for insufflation. The patient is kept in a supine position with the abdomen exposed. The lumen of the gut GI lumen is cleansed using water or antibiotic solution. Any adherent residue present on the mucosa is removed. The steps of achalasia of POEM for achalasia cardia would include the following: mucosal incision, creation of a submucosal tunnel, myotomy, closure of the mucosal incision. The mucosal incision, it helps to pass the gastroscope into the submucosal space. The usual site of incision is about 10 centimeters above the GOJ. However, in spastic disorders, it's about 15 centimeters above the GOJ. The approach can be either anterior or posterior. Both approaches are comparable. However, there's a lesser procedure time for the latter. In CMC, we generally follow the posterior approach. The injectate comprises a combination of adrenaline, indigo-carmine, and normal saline. Various knives can be used to make the mucosal incision, as is seen in this picture. The second step is the creation of a submucosal tunnel toward the stomach. The dissection is by a no-touch technique using spray coagulation. The plane between the submucosa and the muscularis is delineated. Blood vessels that are found en route are coagulated using hemostatic forceps. The tunnel is extended about 2 to 3 centimeters beyond the GOJ. Myotomy is the third step, and we start at 2 to 5 centimeters distal to the mucosal incision. A spray coagulation current is used. There are no differences between a selective inner circular myotomy versus a full thickness myotomy, although the latter has a shorter procedure time. The myotomy is extended again 2 to 3 centimeters into the gastric cardia. The myotomy is usually 5 centimeters long. In spastic disorders, it can be about 10 centimeters. The final step is the closure of the mucosal incision. The submucosal tunnel is carefully inspected for bleeding points and tackled. The esophageal mucosa is looked for incidental tears, which needs to be closed. An adequate LOS relaxation is confirmed, and the incision is closed using clips or a suturing device. So to recapitulate the steps that are involved in POEM, mucosal incision, the creation of a submucosal tunnel, myotomy, and mucosal incision closure. The post-procedure care would involve initial nilperoral for a few hours, the giving of antibiotics, analgesics, antiemetics, and proton pump inhibitors. A day later, an esophagogram using water-soluble contrast is performed. If it's normal, a graded diet is given. On the follow-up visit, the Eckhart score is assessed, as well as we would look for any features of delayed complications. What are the outcomes after POEM? As far as efficacy is concerned, a meta-analysis has shown that the clinical success is about 98%. As far as durability is concerned, a prospective study which had a mean follow-up duration of 75 months reported an overall success of about 80%. How does POEM compare to laparoscopic Heller's myotomy? An RCT which was published in NEJM in 2019 showed that the efficacy was similar at 2 years of about 80%. POEM had a lower rate for severe adverse effects, but a higher rate of reflex esophagitis of about 40%. A meta-analysis which comprised of cohort studies of both POEM and lap-Heller's myotomy showed almost similar results. In type 3 achalasia, on comparing POEM versus lap-Heller's myotomy, a retrospective study showed that POEM had a better clinical response, a shorter mean procedure time, and a longer length of myotomy with lesser adverse events. So it is considered to be the preferred form of treatment in type 3 achalasia. How does POEM compare to pneumatic dilatation? An RCT published in JAMA in 2019, which was a multi-center study, showed that POEM had a higher treatment success at 2 years. There was a perforation which occurred after pneumatic dilatation. As expected, reflex esophagitis was much more common after POEM. The adverse effects following POEM are mostly mild and self-limiting. Capnoperitoneum is generally small.
If it's large, the treatment is by decompression using a Veress needle. Subcutaneous emphysema can be seen in about 15%. Capnothorax can be found in less than 5% if it is large and significant, a chest tube is placed. If any mucosal tear is found, it is closed using clips and suturing device. If a mucosal tear is not addressed, it can lead to a rare but a serious complication of mediastinitis. Bleeding can be delayed in 0.7% and the treatment is by using a hemostatic forceps. Gastroesophageal reflux is found in about 40% and the treatment is by giving proton pump inhibitors. 40% of the poem performed worldwide today are done for people who have had previous treatment for achalasia. There can be submucosal fibrosis as a result, and dissection can be more challenging. A systematic review showed that when POEM was used for post-lap Heller's myotomy recurrence, the technical success was about 99% and clinical success of 90%. The adverse events were self-limited. When POEM is used in a situation of post-POEM recurrence, a study showed that the technical success was 100% and the clinical success was 85%. When POEM has been performed in various special populations like pediatric patients, geriatric patients, sigmoid esophagus, the response has been more than 95%, possibly due to the fact that the procedures were done by experts. In obesity, POEM can be performed either before or after a Roux-en-Y gastric bypass. The success is about 80%. There has been no difference between higher ASA score and a lower ASA score when POEM was compared in people with different risks for surgery, and actually people who had a higher ASA score had about 94% success. The other indications for POEM would include various spastic motility disorders of the esophagus, which include distal esophageal spasm, jackhammer esophagus. In these situations, we would do a longer myotomy. A meta-analysis has shown that the pooled success is about 90%. Encouraged by the success that came with POEM for achalasia, people have adopted it for other conditions, one of which is gastroparesis, in which the pyloric sphincter is targeted. A study showed that a G-POEM had a clinical success of about 70% at 6 months. Similarly, variations of the POEM procedure have been used in Zenker's diverticulum and esophageal diverticulum, and these are called as Z-POEM and D-POEM respectively. POEM has led to an interest in performing or going out for other newer procedures in this third space. Examples include a perrectal endoscopic myotomy, otherwise called as PRAME, the indication being Hirschsprung's disease, STIR, which is submucosal tunneling endoscopic resection for submucosal tumors, POETRY, or peroral endoscopic tunneling for restoration of the esophagus in a situation of complete esophageal obstruction. I'd like to conclude by going through the management algorithm in achalasia cardia that is advocated today. When a diagnosis of symptomatic achalasia cardia is made, patients are divided into either those with low surgical risk and those having high surgical risk. If there is high surgical risk, pharmacotherapy or botulinum toxin injection can be given. For those with low surgical risk, they are subclassified as having type 3 achalasia or non-type 3 achalasia. For type 3 achalasia, a tailored POEM is performed. Tailored POEM is nothing but a POEM with a longer myotomy. For type 1 and type 2 achalasia, patients are classified as being younger or older. If they are younger, the treatments that can be offered include POEM and Heller's myotomy. If they are older, POEM, Heller's myotomy, or pneumatic dilatation can be offered. If one of these fail, the alternative can be given. And if that also fails, the final resort is doing an esophagectomy. So that's all I've got to share today. Thank you for your patient listening.